teams. Welcome to the behavioral support rounds. Today we'll be going through an overview of Baycrest at Home and its collaboration with Toronto Grace Health Sciences Remote Care Client Monitoring Program. So I'm going to go through acknowledgement and land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest and our related to Toronto Central area behavior support programs operates on the traditional territories of many Indigenous nations, which have cared for the land of thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples, and we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the Dish with One Spoon Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which we are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. I would like to review some participation guidelines. This session is being recorded and will be archived on Ontario's CLRI and BSO websites. Your microphone is automatically muted. We will have 40 minutes of presentation followed by 15 minutes of discussion and a wrap up. Please place any questions you have in the Q&A. If you have questions related to tech support, please message Agnes. You'll see her listed on as telehealth. For those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form that you will receive afterwards. So today's presenters, we have Simon Cheesman and Yuliya Goloida. Sorry again if I mispronounced that, I knew I probably would. So in terms of the introductions, Simon has worked in the field of telemedicine and healthcare innovation for more than 20 years. He's the director at Baycrest at Home. He has experience specializing in new models of care that use innovative technology and the health needs of older adults. While at the Ontario Telemedicine Network, he helped to pioneer a variety of virtual care programs across the province. He joined Baycrest in 2016 to help establish the Centre for Aging and Brain Health Innovation, known as CABHI or CABI. In 2020, he helped found Baycrest at Home, a service that uses virtual tools to help older adults and family caregivers age well in the place they call home. Yuliya is the social worker for Baycrest at Home. She holds a master's in social work with a specialty in geriatrics. She's been working at Baycrest for the last 5 years with roles in hospital inpatient services, seniors counseling and referral services. And her current hats also include counselor providing one-on-one and group support while serving at Baycrest at Home's dementia coach and education facilitator, leading a virtual learning series for caregivers. So welcome. And at this point, I am going to stop screen sharing and allow for our speakers to take the lead.
Thanks very much, Kara, and thanks for the introduction. And thanks everyone for spending some time with us today and giving us a chance to tell you more about Baycrest at Home and our project with Toronto Grace Hospital. And without further ado, I'll start sharing my screen and the slides we've prepared. There we go. Let's see, things move ahead. So first, I have no conflicts to declare. Neither myself or Yuliya have conflicts to declare. Our funding comes from the Ministry of Health and from the Baycrest Foundation. So I'll start with saying what I'm going to say, and then I'll say it, and Yuliya and I will say it, and then we'll have a chance to ask us about what we said. So we'll start with a general frame, which sort of talks a little bit about the context of Baycrest at Home and what we're trying to do and the relevance of this solution for the healthcare system at this time about aging in place. We'll go a little deeper into Baycrest at Home. We'll talk about our project with Toronto Grace Hospital. And then we'll end on a note that I hope brings it full circle around some of the challenges that that stem from some of these more innovation-oriented pilots and how we're seeking to address those challenges and how it specifically relates to the behavioral support group as well, because you are part of this picture. I'll start by saying that we gave an overview. I gave a presentation a month or so ago about Baycrest at Home and TJHC, and Jordan Holland joined us for that too. And we talked a little bit about how we were each working with TJHC. So there is going to be some repetition of that material and even some of those slides. but we're also taking a little bit of a deeper dive into this pilot in particular, and how the first phase went. And so there are some new details as well. So don't leave if you were there for that presentation. And so we'll get going on this agenda. So first, I'll start with a way that I think many presentations you guys attend probably starts, and that is talking a little bit about the context of the challenges to the healthcare system, especially, yes, as our demographics are shifting and as the number of older adults in our population shifts. This is not in itself a bad thing. I think that the terms of silver tsunami and that kind of things are very negative and overblown, and betray a sort of ageism that we just don't buy into. But that there is some truth to the fact that a lot of the systems, especially the health system and long-term care system that we set up many, many decades ago to serve our society and our population, it had some assumptions in mind, and the number of older adults was one of those key assumptions. And the healthcare system that we've been living with for a long time reflects that. It's still very much a fee for service, break fix model. Is very good at helping people who walk into a hospital and then walk out and go back to some semblance of their life before the accident. Whereas we know with older adults, the kinds of health challenges they experience and their impacts on the world around them are quite different. Chronic diseases are things that we live with and will live with for the rest of our lives, and take a different style of care altogether. And the health system is still in the throes of transitioning to be really good at serving that larger population. And so there is a little bit of a rocking of the assumptions on which our health system runs today, that Baycrest at Home is part of the response to. And as part of that increased frequency of older adults, then obviously the frequency of age-related conditions like dementia are more frequent, and this has a particularly acute impact. Dementia is a very strong challenge for caring for older adults, especially when we think about the challenge of keeping people out of hospital and out of acute care as much as possible. These kinds of health challenges and for overall quality of life are much better dealt with in the home. The fact is most people with dementia are living in the community, and this in turn presents, and dementia presents a specific and important challenge for the health system, and reflects, and it stems from those larger challenges I just spoke about. So certainly it's impacting a large number of people, especially family caregivers, which my colleague Yuliya will come back to soon, and of course a ton of expense, both for the health system and out-of-pocket expenses for people and families. We know that another aspect of these changing challenges to the healthcare system is that many of the solutions that need and supports that need to be brought to bear are not specifically medical in nature all the time. Many of them are medically informed or built on insights from health sciences, but they are themselves not the kind of resources that a doctor delivers or a nurse delivers, that they are often connected to psychosocial conditions and resources available for people to be dealing with the challenges that stem from aging. And just to quote a statistic from CIHI, 1 in 9 people who were moved every year, 1 in 9 people who are moved into long-term care have medical conditions that could be met in the home, and other things are driving them from the home. A lack of flexibility is often cited, financial challenges, supports for caregivers, and those kinds of things, social isolation. And I won't scoop myself too much, because the kinds of things that are driving them out of the place they call home, as we like, or the community more generally, were nicely summarized in this recent report from the National Institute of Aging, which organized a lot of these factors into 4 well-defined pillars, and collected a lot of the evidence behind them. And a lot of the evidence points to by the fact that if you address these issues, you are effectively extending time and quality of life in the home, which is very important, not just for it's not just because it's what we all want, including myself in the future, but it's also the best way for our healthcare system to adapt and evolve to meet the needs of our aging population. So just quickly to go over them, we're going to be sending out these slides, so some of these references will be available to you. And of course, the report itself is freely available from the NIA. But the first pillar is about preventing chronic disease, promoting good health, slowing the progress of chronic disease and their effects. And of course, this is something that can, and this includes dementia in many cases, but also physical frailty, things that are underlying causes of physical frailty. Home care and caregiver support. Caregiver support, again, as I said, we have a very strong focus on this particular need, and we'll be coming back to it in more detail in a moment. But of course, also the presence of paid support in the home too is a critical factor. Accessible and safer environments. So we know injury in the home is often a triggering event for going into acute care, which in turn is a huge risk factor for being having to leave the home on a more permanent basis. And then also just being able to access and move about your home effectively impacts ADLs incredibly. And so this is a contributing factor that needs to be addressed. And then finally, another really important focus for what we do at Baycrest at Home has to do with social connections, loneliness, meaningful activity, the risk for isolation, and how all those issues hang together for the older adult, often for family caregivers as well. But there's an increasing amount of evidence that shows that this is a really significant factor in what drives people from their homes, and as much as a fifth or a quarter could be connected to that move to long-term care. And it's something I'll talk more about in terms of the solutions in a moment. So that does bring me actually to Baycrest at Home. So with that as a framing device, I'll just end on a note of saying that it's staying in the home with a good quality of life and health is a complicated problem without a single solution. It is a problem that's multifactorial, and it requires multiple solutions. And where multiple solutions are involved, obviously coordination and patient-centeredness are really critical. Understanding the needs and bringing the right solutions around the needs of that patient, and actually from our perspective, even more importantly, the dyad or the triad, the unit that is there in the home, helping to keep that person well and safe. And that's of course incredibly important in the presence of dementia as well, where the ability for self-care is much impacted. So I'll come back to this towards the end of the presentation. I'll talk a little bit now about Baycrest at Home. I'll set it up, and then I'll hand things off to Yuliya to go a little deeper. But in general, Baycrest at Home is a virtual wellness program and platform that delivers a variety of interventions that target the health and social needs of older adults and their caregivers. And our goal is to do a longer-term intervention that promotes. Specifically today, we have a strong focus on promotion of wellness, social connectedness, capacity building for caregivers, and support for caregivers. And we bring those together in a package of virtually delivered services that are meant to go well beyond the Baycrest population. We have a goal of reaching as many people as possible in Canada and to have a large impact. This is pretty much what our clients look like. Obviously, there's exceptions and one-offs and exceptions that prove the rule, but we are usually we're always building our services with these people in mind. So as I said, the dyad is important. We think of them as a collective, as people who are working together to maintain their quality of life and time in the home. Those caregivers are very often adult children. About half of the time they're spouses. Most of the time they're women. And many times we also have caregivers that are not in the home. We have people who are nearby the home, living in the home, and many of them are far away as well. And that speaks to the power of a virtual-based service that we can often stitch together the people who are trying to do that support from afar. So here I'll hand things off to Yuliya and let her talk a little bit more about caregivers in particular.
Okay. Thank you so much, Simon. So just keeping in mind our last slide, talking about the types of caregivers we see coming through our doors at Baycrest at Home, I want to take a step back and look at our Ontario perspective on caregivers. So these stats are from 2020, so a little bit dated, but we saw that 3.3 million people living in the province are family caregivers. That's 29% of the population. Of those folks, 76% juggle between caregiving and employment. When we think about that, we think of the sandwich generation, those people that are caring for maybe older parents as well as children or grandchildren. And of these caregivers, we've seen 35,000 people struggling with their employment, having to leave work either because they had to quit or were fired because of challenges related to caregiving. We also see that the median rate of depression for older family caregivers is double that of older adults who are not caregivers. And this is important to recognize as we look at some of the reasons why caregivers experience stress and burnout as a result of their caregiving. Next slide, please. So taking a little bit of a broader look at caregiving, what do our stats in Canada say? So 1 in 4 Canadians provide care to a family member or friend with a long-term health condition. This can be both physical or a mental disability, and often it's because of age-related needs. Almost 600,000 people in Canada are living with dementia in 2020, and this number is projected to rise to almost 1 million by 2030. Almost 250,000 people living in residences for senior citizens have moved to these residences because of cognitive or physical impairment. And just 19% of caregivers who provide 1 to 3 hours of care per week reported that this was stressful or very stressful. And I'll tell you that just working at Baycrest at home, many of the caregivers I interact with are doing many more hours than this. So to recognize that even when you have just a little bit of caregiving demand, it can really affect someone's life and well-being. Next slide, please. So as we talk about caregiver stress, we need to recognize that it can lead to multiple negative outcomes. So first and foremost, as we looked at some of those stats, we do see an increased psychological distress being reported by caregivers, and this is marked by psychological illnesses like anxiety, depression, which can often be characterized as burnout. We also see that when there is this psychological distress, it can also lead to poor physical health outcomes. Folks may not be exercising as much as they need to, or eating well, or not prioritizing their health needs. We also know that psychological distress can lead to other physical health challenges, and all of this leads to an increased risk of mortality. Through all of this, caregivers report an overall decreased quality of life. And we've seen firsthand how this burden has multiplied through COVID. So for the caregiver themselves, we saw an increase in social isolation, a decrease in access to services. So whether services closed down because of the inability to provide safe services, or because of a lack of funding or too much demand on those services. And now that we are out of the pandemic, so to speak, we haven't seen those services kind of restart to the same capacity that they did prior to the pandemic. So this is still having an impact on caregivers. With all of this, there's also increased financial burden to the family caregiver as a result of the needs of the person they're caring for. And all of this places additional stress on the healthcare system, making this a public health issue. Now, the first step is recognizing that recognizing caregiver stress is the initial step in realizing that these people need support. And fortunately, caregiver stress can be prevented or reduced with appropriate awareness and interventions. Next slide, please. So when we look at the target of our interventions, they often fall in 3 categories. So either the intervention is geared towards the care recipient or the patient, to mitigating some of the risks in the social or physical environment, or towards the caregiver. The most effective treatments target more than one area of the intervention, and all 3 of these interventions affect the caregiver well-being. So if we can impact something for the care recipient or change something in the physical environment, that can also have a positive impact on our caregiver. Next slide, please. Now, what does the research say about what our caregivers need? What's the best support to give caregivers? And it falls under some of these different categories. So the first one is to strengthen the caregiver competence. Often we hear from caregivers, I just don't know what to do. I don't know where to start. I'm not sure how to handle this. We also need to provide people with evidence-based information and give them the right information. So it's not often an issue of a person not being able to find information. The internet is a very vast place to look for answers, but it's helping the caregiver to find the right information at the right time to help them weed through this vastness of resources that are available. And in so doing, we help caregivers develop task-specific and problem-solving skills. We also support caregivers through psychoeducational interventions, and I'll talk about this at length in the next coming slides. And we also need to support caregivers through navigating the service delivery system. I'll tell you firsthand as a social worker, this is a large part of my job, and it's also something that we as healthcare providers sometimes struggle with. The benefit we have is we have colleagues that we can email or call or ask questions to, and that's a resource that many caregivers don't have. And so that brings us to linking caregivers to appropriate resources, again, in a timely manner. Next slide, please. So this all brings us to Baycrest at Home. And as Simon touched on, our goal with Baycrest at Home is to support the caregiver as well as the care recipient. And so we do that in two sides of our service offering. So in support for our caregivers, we help them along their caregiving journey. So at different points, we have different interventions that support them and their changing needs. And for the older adult, we offer evidence-based dementia-inclusive programming that focuses on physical, cognitive, and wellness goals. And we'll talk about that in the coming slides. So starting with our wellness platform, as you see here to the left, this is a screenshot of our website where our clients can navigate and get onto our different programs. And we offer our programs in a variety of wellness pathways. So to start, we have our exercise programs or movement-based programs that incorporate different types of exercise to meet our different clients' needs. So those who have a little bit more balance and strength may choose to do things like vigorous cardio or strength training. We also have wonderful programs facilitated by our partners, such as the National School of Ballet, who does a great program on sharing dance. We also have other wellness streams. So our cognitive stimulation stream focuses on things like brain games, discussion groups, tech literacy, and trivia. And many of our programs are attended by both the care recipient and their caregiver, whether that's a family caregiver or a paid caregiver. So when we say dementia inclusive, what we mean by this is our programs are geared to people at different levels. So our members are able to choose the pathway that suits their needs and their changing needs. Our social engagement incorporates things like group-based learning and storytelling, as well as peer support, where our members connect with one another and share about their experiences. We also have our mental health practices. So for example, a mindfulness group that I facilitate, as well as programs like Tai Chi, a forest bathing program that's facilitated by a wonderful horticulturalist. So we really try to diversify our offerings as well to meet people based on their different interests. And we've also recently added our health education stream. And this is great for both caregivers and our members, our care recipients, who are interested in affecting some of this wellness change in their lives. So we've had guest speakers, doctors, and different industry leaders come and present on a variety of wellness topics, including things like mood management, sleep hygiene, and falls prevention. Next slide, please. And here's a great shot of one of our facilitators, Patty. Patty does a lot of our movement-based programs. Here she is doing our seated exercise class. And so one of the learnings we've had is actually to facilitate these programs at different times of the day. We saw that for some folks, right in the morning is a great time to do exercise, but other people have shared with us that they would like to do exercise in the afternoon. So we've been able to shift that and lead with our programming to meet our clients' needs. Here's another example of our programs. This is Bailey, who facilitates an art program. So in this program, we've actually sent our members the necessary supplies so they have them in their home, and they're able to engage live with our facilitator to both do the art as well as discuss it and share with their peers. So this is a really great program that has been well accepted by both our members, and we've had many caregivers attend as well. Next slide, please. And so, as I mentioned, we have many programs that are live and facilitated every day, but we also have a growing and robust library of recorded and archived programs. So this is really good on the weekends where we have less facilitated programs, and also as a great tool and resource for family caregivers to have to support their person as they need. So in the evening when adult day programs are closed or our programs are not running, this is a great way to engage their person and provide them with a variety of programs as well. And it also gives them some of that familiarity of seeing their facilitators that they engage with on a day-to-day basis. So shifting gears a little bit, I'm going to start talking about the other side of Baycrest at Home with our clinical services, or our services geared towards our caregivers. So the way that we assign our programs or help our caregivers to determine what's going to be best for them is often through a consultation. So we'll have a lot of ways that people come through our doors to receive support. It might be through a referral of a healthcare provider, whether it's in the community or in Baycrest, or they might have, stumbled upon us through an internet search. And so we get different varieties of inquiries coming through where somebody may indicate just very broadly some of the challenges that they're dealing with, or they might tell us exactly what they're looking for, a support group or counseling needs. But what we do for all of our clients is a complimentary consultation. So our social work team or a clinical team will actually get on the phone or book a Zoom meeting, and we'll connect with the client and learn more about their story. And in so doing, we'll actually help to map what their caregiving journey looks like and the different supports that they may benefit from. So a person may come through our doors looking for a support group, but we actually identify that they may need a little bit of education before they jump into a support group, to give them the tools and the foundation to be able to really take part in that support group and benefit from the peer support and sharing without having to answer questions like, where do I buy a walker? And, how do I get a memory assessment? So some of the different things that we offer as part of our clinical services, as I mentioned, is the dementia-specific education program that's geared towards family caregivers. We're also developing a similar program for paid caregivers. We offer individual and family counseling, and that's both for emotional support needs as well as to help people problem solve, future plan, and develop, supports to navigate the healthcare system. We have our different support groups geared towards caregivers. And Baycrest at Home has also allowed our platform to support other kinds of support groups. So we've had an arts-based group that's run a few sessions on our platform, which has allowed really beautiful self-expression and a creative outlet for family caregivers. So we've been really privileged to have that as part of our service offering. And as I mentioned earlier, our caregivers also have access to those same programs that we offer to our members. So the mindfulness program, Tai Chi, some of those health education seminars. And so those have been really well received as well and offer additional tools and resources for our caregivers. Next slide, please. So here's a closer look at our support group. So all of our support groups are offered on a virtual channel, just like most of Baycrest at Home. And in so doing, we found, especially during the pandemic, that this was one way that we were able to reduce the barrier for our caregivers. And we asked ourselves the question, when the pandemic ceases, will people want to continue in this virtual capacity? And one of the greatest learnings we saw from this is how much flexibility it gives to our family caregivers. So before virtual services really took off, caregivers often had the challenge of, what do I do with my care recipient when I need to access services for myself? And so by offering things like support groups and counseling, in a virtual capacity, the caregiver now doesn't have to worry about finding, care for their person. They can freely be in the same home, maybe separated just by rooms, or having headphones in, and that allows them a little bit more privacy. Another learning that we had, within Baycrest at Home is, how best to offer our groups in a timely manner. So traditionally, you would hear about support groups being very homogenous. So either geared towards spouses or adult children, or focusing on a specific, subtype of dementia, whether that's frontotemporal dementia or Lewy body dementia. And when we first started Baycrest at Home, this was the manner in which we were facilitating our programs. This was the best practice. But one challenge we saw was that it was quite difficult to fill up an entire group, of participants, and then have all of their schedules coincide to find the right time to facilitate this group. And so what we had was caregivers waiting on the wait list, or maybe, one person who doesn't really fit in with the rest of the group, just based on the outward criteria. And so people would essentially fall through the cracks. And so what we did is we shifted our model a little bit, and we've created a mixed format. So now we have caregivers who are spouses mixed with adult children, different types of dementias. And in so doing, we've been able to offer many more cohorts of our support group. We focus a little bit less on, what differs between the caregivers, and more on the common threads. Because we recognize that although everyone's experience with dementia is going to be different, there are going to be many similarities. And so we focus on the things that we can learn from one another. And it's really strengthened, the way that we facilitate these groups. And as we do with all of our clinical services, we have a robust evaluation format, and we've been able to see that there are still quite positive outcomes. And the feedback we're receiving is quite good, that people are still receiving a lot of benefit from this service, even though it doesn't fall into those traditional guidelines of what best practices dictate. And so here is another snapshot of our clinical service, the education series. It's called Caregiving 101. This is a program that I facilitate along with my colleague, Selena Chan. And this program was developed based on the knowledge that's in the manual here, Dementia Caregiver's Guide. It's now in its 3rd edition, and this is a manual that was developed at Baycrest with over 20 years of research and the insight of occupational therapists and physicians and nurses and social workers and recreation therapists. And so this course we've developed on the platform of Baycrest at Home to really help caregivers through those early and middle stages of caring for somebody with dementia. We focus on things like preparedness, helping them to understand how this illness functions in the person on a day-to-day basis, and helping them to accept what the interventions are trying to do. So oftentimes we'll have caregivers come through our doors and take part in the program. And on the very first lesson, we talk about what is dementia. And you'd be surprised to hear how many family caregivers who may be caring for somebody for 3-4 years don't quite understand what dementia is. So in the shuffle of having somebody diagnosed and getting them on the right medications and signing them up for home care, family caregivers don't often understand, how they can support the person because they don't understand the illness they're dealing with. And so we really try to break it down to the fundamentals. What do caregivers really need to know on a day-to-day basis to not only support the person they're caring for, but also themselves? So this course is 8 hours of facilitated content. We do it over a month long, so there's 2 lessons per week. And in that time, we have 2 whole lessons that are dedicated just to caregiver supports and information that they need to know, help navigating the healthcare system, resources that they should be aware of, ways that they can support themselves through self-care and positive health strategies. And so all in all, this supports them to have better outcomes in their own health, as well as the care of the person they're looking after. Next slide, please.
Great. Thanks, Yuliya. That was amazing overview for me too. I enjoyed that. It's great to see it up close like that and from your perspective. So I'll end on just a couple more pieces of information in terms of the scope of our reach and where we are today. So these statistics cover the last 2.5 or about 3 years. And over that time, we've had about 1,000 people come through the program, either as caregivers or as participant in our social and recreational offerings. So that can range anywhere from a few hours of consulting to many months of being a member on our program. The number of people who've come to our virtual and social recreational events is really adding up. This 17,000 is old and needs to be updated at least by another 1,000 now. So we've had many thousands of participants, although many of them are the same person over and over, as you can imagine, but they're now in the tens of thousands of people coming to those. And overall, hundreds and hundreds of hours of one-on-one consulting, group counseling, and psychoeducational interventions have been delivered to those people as well. We also work very closely with people like, for example, Adriana Schnall, who does a monthly webinar series, and we support that in a variety of ways. And it's part of another way in which we reach out to the caregiving community to deal with a lot of the issues that Yuliya just reviewed. We have ongoing PE, program evaluation, and an early stage research project associated with what we're doing. So these numbers refer to our program evaluation, which we do have KL Care, the Kunin Lunenfeld Center for Evaluation, for Research and Evaluation. They do it for us, but this is not an REB research numbers. These are just ongoing monitoring of satisfaction and stated impacts on the members. So we see very high levels of satisfaction and value. So we ask those two things separately. Are you satisfied? And is this valuable to you? And the vast majority of people find it so. We do have the vast majority of people saying that it positively impacts their overall quality of life. I'm covering over some of my own statistics. Oh yeah, that over 80% experience a reduced burden. That's from the caregiving side of the equation. Over 70% are seeing positive benefits to both physical and mental health, and a small majority of people are saying that this is directly contributing to their ability to remain at home. And these are early days, so we're really trying to hone in on what makes a difference in that last stat specifically. It's a difficult one to measure and to prove out, but it's our North Star. So we're always looking to see what makes that number go up and where we can make our greatest contributions. I showed you an overview of the personas of our end users, and it's that dyad of the caregivers of people with early to moderate cognitive decline, physical impairments, and their family caregivers. But increasingly, although we started Baycrest at Home as a direct-to-consumer offering or a direct-to-client offering, with a fee structure around it and subsidy for people who couldn't afford it, we're increasingly and now very importantly focusing on reaching people by working with other organizations that are serving that target population. And obviously our project with Toronto Grace Hospital is a really important example. It's not our only one though. We also are working with a number of home care agencies in different capacities. There's an exciting pilot in the go that I can't mention too many details about yet, but we're going to be doing a pilot with a home care agency in Ontario. And then we also work with congregate care organizations in a slightly different model of care where we're bringing it to the individuals who live there in the congregate setting into their rooms as individuals, but we also serve congregate settings, group settings, where people can enjoy some of the social and recreational content as a group. Here's just a logo cloud of some of the people we're working with, Loft for a number of years now, and a number of organizations across Canada. That is a segue into this project because we are among those organizations is Toronto Grace. The purpose of this, the overall purpose of the pilot is that they had an existing remote client monitoring intervention that started with a focus on their own ALC patients and using technology to put those people back into their homes earlier or faster or at all with the supports that they put around them. And we wanted to come together when we met each other and we saw the different kinds of services each were offering. We realized that this would make a great combination, that our virtual supports for caregivers and issues around wellness and social isolation really complements some of their more clinical and safety monitoring interventions, and that together it would be a more effective age in place. I've jumped onto the next slide. I didn't mean that. I segued too much. So I to land the point of this slide is that their project is a remote client monitoring initiative where they're now monitoring thousands of people. They started with their own hospital, but they have many referral partners across the GTA and beyond. And I'm sure these numbers are a little bit out of date, even just being a couple months old. They're receiving about 30 referrals today. So it's found an important niche in the health system, and people are referring into it to help their patients make that step down into the home from different parts of their hospital. So their eligibility is as you see it. I won't go into the nitty gritty here. Basically, they will take anybody with OHIP coverage, people who need help with safety and management in the home. They have certain exclusion criteria, for serious high-level monitoring. For people who don't have a home to go to, of course, it's an unfortunate situation. And then people are discharged if they pass away or if they have to go to long-term care. The kinds of interventions they make are represented here by showing the different technologies they use. So in terms of safety and movement in the home, they have wearables that provide GPS tracking, two-way audio communication, and alerts that will go if somebody crosses certain geofencing criteria that are put into the device. And they also have sensors in the home that can track movement within the home. So, for example, a lack of movement for a period of time would trigger an alert, or leaving the home could be used to trigger an alert, but it is used to monitor safety. They can do vital sign monitoring. They do blood oxygenation, pulse rate, and temperature, those kinds of things. Not everyone gets everything, I should point out. They tailor this service to the needs of the client. And then some clients who have issues around taking their medications can get access to the specialized device you see on the far side of the slide. It's a device called Carry from a company called AceAge, and it is a smart pill dispenser that uses strip-style packaging to feed out at the right time the medication for the person to take. It beeps and reminds them. If the person doesn't take it, it will notify a designated caregiver that the medication wasn't taken. So it brings a caregiver into the picture. And this is where I scooped myself, talking a little bit more about the purpose of the pilot itself. It was to bring our two programs together to see how it enhances the overall effectiveness of the program. We received funding from Ontario Health to do this. We applied together to the remote client monitoring program. In the end, we were funded out of a different pocket from the ministry, but that's a long and boring story. But the exciting part was that we were able to get to do the project with the target of referring 250 patients to the program in a very short period of time. So through the long and boring story that I won't get into, the project started quite late in the fiscal, but still had to finish within the fiscal. So working together, and I don't know if anyone from Toronto Grace is on the call, but their team was so fantastic, dedicating resources to finding those patients that fit our own criteria around caregiver supports and at risk for social isolation and other wellness related issues, to find everyone that came in through their doors and getting them referred over to our program. So we finished phase 1 successfully. It's now in our rearview mirror. I'm excited to say that very recently we heard indication that we would be renewed to continue our work together. We never stopped. We kept working together to continue to take referrals in from this program and support them with this combined program. But we're really excited to see continued faith and support in this initiative together. So we're still a going concern, and still looking to build knowledge and insights from what we're doing. We're just receiving some of our evaluation data from this specific project. I just saw it for the first time yesterday, so I won't go into the details, except that we saw some very exciting top-line results that showed that we were making impacts where we were hoping to make impacts in terms of their quality of life, sense of burden, and physical and mental health. So great stuff, and it continues today. So I'll just hand things over to you, Yuliya, to take us into some more of the details.
Yeah, so I'll just briefly touch on, who these clients are that are coming through this pilot, and some of the inclusion and exclusion criteria. So as Simon mentioned, these are dyads. So we're often seeing an older adult accompanied by a family caregiver. And so for the older adult to come on to the Baycrest at Home side of the programming, they need to have indicated, that there's going to be benefit in them receiving the wellness program. So they don't have to do all of the different wellness streams, but at least one. So whether that's, a focus on physical health, that movement-based programming, some mental health support, areas to reduce social isolation, improve cognitive stimulation, or, all 5 of those categories. And then for their family member, there is a point here that it can be chosen family as well. There doesn't have to be a blood relation. They don't have to live with the person, but for that family member to benefit from our caregiver support services. Some of the other inclusion criteria, so the individual for social recreation needs to be medically stable. Part of the reason for that is, our facilitated programs are remote, so we can't monitor that everybody is able to do things, in a 100% safe manner. So there needs to be some self-regulation there. We also need the person to be psychiatrically stable and have unmanaged, not have any unmanaged behaviors. And caregiver proximity is also important to note here. So the caregiver doesn't necessarily need to live with the person, but it does benefit if they have somebody that, comes to see them from time to time, can help with any, technology resolution issues. We do have tech support available through Baycrest at Home, but it helps a little bit if there's another person that can facilitate some of that support. Cognitive impairment is also an inclusion criteria, and the person needs to be at least 55 years old. For the caregiver, the person that they're caring for should also have cognitive decline for them to benefit from our clinical services. As I described earlier, they're quite geared around dementia and cognitive impairment. And for the caregiver to take part in our services, the other half of their dyad doesn't necessarily need to do our wellness programming. So we did see referrals come through where maybe at the onset, both people were referred, to wellness programming and the caregiver to our clinical services. But if the person doesn't want to engage in the wellness programming, we will still support the caregiver with our clinical services. So that's not an exclusion. And same for the caregiver. They should be psychiatrically stable, and for their care recipient, no unmanaged responsive behaviors. So now I want to just take a brief snapshot at what this client journey actually looks like. So we've talked a lot about inclusion and exclusion criteria and how does it actually look? So we receive a referral a referral will be made to TGHC by the patient's healthcare provider. And this can either be a direct or primary healthcare provider, like a physician or a nurse, but it can also be one of the many referring agencies. So if I can just recall from the list, the Alzheimer's Society is on there, home care services. So there are a lot of referring partners that are able to take part in this program. From that point, Baycrest at Home would receive the referral with an indication of, the dyad being interested in caregiver supports or wellness programming or both. And at that point, our clinical team of social workers would do an intake and assessment. And at that point, we would identify goals and prescribe interventions. So as part of that, we would try and help the caregivers who are often, quite overwhelmed. And we would try and assign just one intervention. So similarly to how we carry out our services in Baycrest at Home for, people that come through our different channels, we also really want to understand the person's history. We want to know where they're at in their journey and what is going to be most relevant and most timely right now. And we would prescribe that service. So although we had a lot of referrals coming in at the same time, we had people being prescribed things like a support group, or doing a little bit of counseling before they joined a support group, or starting with our education series. And beyond that, once somebody finished an intervention, we would reevaluate and see what new goals would arise. And if that caregiver was responding well to our intervention, we were happy to follow through with them and prescribe another intervention and continue along with their journey and journey with them. So to illustrate a little bit about the caregivers that we were seeing coming through these referrals, often what would precipitate the referral to Toronto Grace was a recent hospitalization. And it wasn't, just a regular hospitalization. It often resulted in the care recipient having a significant change in health status, which often also exacerbated cognitive health issues. So the caregivers we were seeing, when I was doing these intakes, they would list off, at least 10 physical and mental health challenges that they were dealing with, with their care recipient. So quite complex medical situations. Often the caregiver themselves also had physical or mental health challenges, which complicated their ability to navigate, the challenges they were in, to be able to, find appropriate resources. Often we also saw financial strain or difficulty related to the caregiving needs. So many people who were already connected to home care, the home and community care support services, or who were awaiting long-term care. And almost 100% of the caregivers that I interviewed described caregiver stress and burnout. We had a question on our intake that asked, what do you do for recreation, or what do you do for self-care? And very often caregivers would report that they had no time to do that. And that's one thing that we really sought out to change as we were engaging in these interventions, whether it's through counseling or support group, was to encourage our caregivers to prioritize their own health and care needs. So I had one caregiver who booked herself a doctor's appointment after not being to the doctor for 3 years, as a result of the pandemic, and also having to care for 2 aging parents. So we were really seeing people who were struggling after many challenges, but we're also able to support them, in a timely manner.
Great. So I'm conscious of the time. I know we'd like to leave time for questions. So I'll just end on two quick points. One is that we're aware that the BSO is also involved in Toronto Grace Hospital, and we know this because we wanted to make a point to know it. We were working with Danielle, who is our contact at TGH. She said, I'm working with Jordan, where we have this project, and so we immediately saw a danger here. And it's often a danger that impacts a lot of innovation and pilots around innovation, things that are out. To be frank, the health system in general, around coordinating services around a patient, there's probably some complaints that can be made in most cases. We do our best. But when you're starting to bring virtual, or often it's connected with virtual because they're innovative pilots, they are even more siloed than before. So we didn't want Baycrest to fall into that within our own family. And so we reached out. Jordan was very happy to coordinate our work together. So our pilots are not in any way formally linked, but we shared information. We were transparent about what our evaluation frameworks. We shared all those resources. KL Care was a common touch point. And the result we wanted to have was to take a lot of these important services that the 3 different programs are providing, or around clinical support, safety in the home, accessibility in the home, social isolation, caregiver support, your own specialized form of caregiver supports around behaviors and information, and to bring that as in a patient-centric manner as possible. And a big part of that is to work well as a team. And I really thank Jordan for helping us to do that, and we will continue to do that, I hope. And so my final point is just to show that picture again. These overlapping discs represent the 4 pillars of the recipe for aging well, aging well in place. And I've taken these screenshots and images are meant to represent services from all of our programs that meet those different needs, around chronic disease management, social isolation, safer environments, and caregiver supports. And that and when we're doing our job right, the picture of our services come together in this kind of approach. And we're hitting a lot of those important points. So I'll end there and welcome your questions. Anything that we've said that may have raised comments or questions.
Thank you so much, Simon and Yuliya. This is really, really informative. So at this point, we have about 5 minutes. So if you want to use the Q&A or the chat box, please go ahead, and we'll give you the opportunity to ask any questions at this time.
I'm not sure I understand.
Here's my Siri talking to me.
I'll answer a question that we're often asked while people are getting up the nerve to type something, which is often comes from your group, which is around your ability to refer into us and the cost to your clients. So the nice thing about this relationship with TGH and that your own familiarity with that program is that you can refer to us. When you refer into the TGH, you can highlight these needs for your patients and they will get access to Baycrest at home. So I just wanted to clarify that up front as well. We find that, as you saw from some of our criteria, that people with uncontrolled responsive behaviors, which I'm sure you have a lot of contact with, don't always make the best candidates for our social recreation, but people change over time. And so that's something that we can revisit. But caregiver supports is very often a relevant resource for your clients. So I just highlight that for you.
Wonderful. So yes, you just pretty much answered the Q&A question, which is what's cost involved, and then also can long-term care get access with the monitoring product?
I'm sorry. Go ahead. Yuliya.
Yeah, I believe one of the exclusions is if somebody is in long-term care, they're not eligible for the monitoring. So it's just for community-based clients.
There's another question in the chat box saying, can you refer directly to Baycrest at home without going through Toronto Grace?
We believe in no wrong doors, so we will not ignore you if you refer directly to us. But if it is appropriate, we'll reach back out to TGH to make sure it comes in through the door where it's through that funded program. But don't hesitate to start with us, especially if you just have any questions about the applicability of the program to your client or you want to talk things over first. But yes, you can go to either door and they'll reach us.
And can a nurse just send a referral? Does the nurse need to fill a referral?
I'm hesitant to answer on behalf of TGH, so I can get back to you with the right answer to that. Like when you make we get a referral from TGH that has gathered a little bit of information and comes across as a secure email. So I imagine that they have a bit of a form, but I can get the details out a lot when I send back out the slides to Kara.
Mm-hmm. I will say I have referred somebody, through TGH. So the referral form can be done by a nurse. You just have to be part of, some of the referring partners. So, if you belong to a major hospital or a community organization like, Community Care or the Alzheimer's Society, then those are eligible referring partners. The referral form, I think, is 6 or 7 pages, but it's very easy to fill out, and you can indicate those different categories. So whether it's just for the remote care monitoring or additional caregiver supports.
Great. And one last comment, just saying Baycrest at Home program seems for higher functioning clients and need of technology to facilitate.
We do serve people from mild to moderate, and the extent that we can serve people with stronger dementia often depends on support in the home. So often accessing the technology does become an issue early into that journey of cognitive decline. We've made it as simple as possible, which is important for the caregiver in the home as well. But we do find that is often a need. And that can be someone coming in, because the program's running hours every day of the week. So if the person's in there on certain days of the week, then that's the days they can get them connected. And over time, we find that more independence does emerge.
Mm-hmm.
Wonderful. Thank you so much. We are at time. So again, I'd like to thank Simon and Yuliya for a wonderful session on Baycrest at Home. Thank you to the presenters overall, of course, and telehealth for helping facilitate everything. Just a quick reminder that if you would like a certificate of attendance, please complete the brief evaluation survey, which will be emailed to you. The recording will be available on the Ontario CLRI and BSO websites. Thank you again, everyone, for joining us, and have a wonderful day. You can see posted here any ways to connect to CLRI as well. Take care, everyone.
Thanks, everyone.
Thank you again,
Thanks.
Simon and Yuliya.